I would like to invite my co-chair, Dr. Gaetano. Sei anche co-chair, devi presentare, e non mi presento da sola.
So, welcome to this session on CLL, and our first speaker is Dr. Alessandra Ferraioli. I think she doesn't really need an introduction. We all know her very well. And the topic she will cover is CLL state-of-the-art update in MD Anderson Cancer Center. Alessandra, please.
Thank you. It's with great pleasure that I'm here, and we always leave the best for last, so chronic lymphocytic leukemia is the most interesting disease in this meeting. And we will now discuss the state-of-the-art update at our center. So just to introduce, we anticipate there will be 21,000 new cases of chronic lymphocytic leukemia in the United States in 2019. The 5-year survival is 86%. And to put things in perspective, in 1975, the 5-year survival was only 68%. We all know that it's the disease of elderly patients with a median age at diagnosis of 72 years and a median age at treatment of 70 years. What we want to do with the work that I'll be presenting is to bring this 5-year survival to be above 90%, and I think this is an achievable goal for 2029. Why we have made such strides in chronic lymphocytic leukemia is because those have been really golden years. Over the last 20 years, a large number of new agents have been made available and then eventually approved. We have gone from combination chemotherapy to combination chemotherapy with monoclonal antibody, and then what is truly revolutionizing the field is the small molecule inhibitors. And small molecule inhibitors either used as monotherapy, combined with monoclonal antibody, more powerful monoclonal antibody, or even combined with cellular therapy. So I think that the goals that the CLL investigators should have for next year is to develop a treatment that is effective, is time limited, it's an oral treatment because patients prefer oral treatment. They also like for the treatment to be chemo-free. We would like the treatment to be safe. The treatment should be friendly to older patients that are the majority of the patients, and also we have to remember that the treatment should be affordable. So at MD Anderson, we're trying to reach those goals, at least some of them, through a strategy of MRD, measurable residual disease directed therapy. This is one of our frontline trials. It's called IFCG. Is a combination of ibrutinib, fludarabine, cyclophosphamide, and a newer anti-CD20 monoclonal antibody, obinutuzumab. This is what the first line is for patients that have mutated immunoglobulin heavy chain gene. And as I said, the primary endpoint is achievement of MRD negativity after 3 cycles of treatment. Why are we doing this? Why we're doing this combination is for several reasons. We are trying to limit the amount of chemotherapy to 3 cycles. The idea is that by limiting the amount of chemotherapy, you are less likely to have treatment-related myelodysplastic syndrome and AML. We are combining it with the small molecule inhibitors with the ibrutinib, and we are using the more powerful obinutuzumab that we all know based on the CLL11 trial is able to induce a deeper response respect to the other CD20. We reach this point because we have a very long-term data from our FCR trial. And what we know now that we have a follow-up that is past the 12th year is that the patients that benefit from FCR are patients with mutated immunoglobulin heavy chain gene. As indicated in the red line, those patients are potentially functionally cured. And what I mean is that 60% of those patients has no evidence of relapse or no evidence of progression at 10 plus years from the start of treatment. Whether this is a true cure or a functional cure in the sense that for the life expectancy of the patient they will not need any more treatment, I'm not sure it makes any difference. We also know, based on the work that was done by the Italians in collaboration with other European groups, that when patients with mutated immunoglobulin heavy chain gene receive treatment with FCR, their life expectancy is similar to an age-matched person without chronic lymphocytic leukemia. So again, we are introducing this concept of cure, either functional cure or true pathological cure. We also know that the best group is the patient with mutated immunoglobulin heavy chain gene that achieve negativity for measurable residual disease up to the -4. In this group, over 80% of the patients are free from progression at 5 years. We don't want to stop, though, at the -4. With the new adaptive next generation sequencing technology, we know we can go to the -6. And this is what we are now measuring on our clinical trial. This is a paper that is in press in Blood, where we were able to show, going back on retrospective samples, the importance of achieving a negativity to the -6. We analyzed different compartments. It's quite a complex paper. However, I think this slide is the take-home message. And that is that for the patients, the best patients are the ones that achieved MRD to the -6 in the bone marrow after treatment with FCR. So this is how the protocol is designed. Everyone received 3 cycles of IFCG, then based on achievement of CR and MRD negativity. The patient that achieve a CR and MRD negativity receive 3 more cycles of ibrutinib and obinutuzumab. They have their evaluation again. If they stay negative, they continue with 6 cycles of ibrutinib only. If there is MRD positivity, they continue with 6 cycles of ibrutinib and obinutuzumab. If they don't achieve MRD negativity after 3 cycles, then they will receive 9 cycles of ibrutinib and obinutuzumab. Everyone received 12 cycles of treatment. If after 12 cycles of treatment MRD is negative, then ibrutinib is stopped. Otherwise, ibrutinib can continue. So this is another very important concept in CLL nowadays, is that treatment really need to have what we call finite, that is limited duration. Is really not realistic to expect that a frontline patient will continue on treatment for years or even decades. Those are the characteristics of the patients. Those were very favorable patients because they were all mutated, and they didn't have, of course, deletion 17p. Those are the responses after 3 cycles of IFCG, very high overall response rate, and very high achievement of MRD negativity. However, you can notice that the achievement of MRD negativity is higher than the complete response rate. And this is because we use CT scan for restaging. And so there were some patients that did not qualify for a CR because of residual lymph nodes of dimension between 1.5 and 2 centimeters. Those are the responses. The responses improve with time, and I would like to point to the blue column where 100% of the patient achieve MRD negativity in the bone marrow at the -4 after 9 and 12 months of therapy. This is how these compare with similar regimen, including our prior regimen, in mutated patients. So the level of MRD negativity achieved with 3 cycles of IFCG is 95% and is superior to the one that can be obtained with 6 cycles of FCR. We again wanted to go deeper, and so those are results with the clonoSEQ assay with MRD negativity up to the -6. And we can see that even if there are a number of patients that are negative at the -4 but will be positive at the -5 or at the -6, those results are quite remarkable. At this point, 37 patients have reached 1 year. All had MRD negativity, were able to discontinue therapy, and we have a median follow-up of 16 months with no one that had relapse. Those are the flat curves we're all used to. So what we plan to do is to expand this trial to 100 patients. We have enrolled 70 already, and to continue to use our MRD achievement for evaluation. Similar strategy by different group, the group in Boston as well as the French group. And I'm gonna run through these slides because I wanna go to the next frontline therapy. So basically what I showed now is very easy because those are the mutated patients, the fit patient for chemoimmunotherapy on frontline therapy. So all those patients are the ones that give us a lot of satisfaction in clinic. We give them treatment, they do great, they stay in remission for years. What about the less favorable group? Those are the patients that have unmutated immunoglobulin heavy chain gene, they have abnormality of TP53, they have deletion 11q, or the older patient that cannot receive treatment with chemoimmunotherapy. You probably have seen these results published in the New England. This is the combination of ibrutinib and venetoclax that was up to now our frontline study, now as complete accrual. 3 months of ibrutinib. At the first week of month 4, we started the dose escalation with venetoclax. Those are the patient characteristics. Again, those are very unfavorable patients, much more than before, with 92% of them having at least one unfavorable feature. We were able to reduce the risk for tumor lysis by using the 3 months of ahead ibrutinib. So we didn't have any clinical tumor lysis. We only had 2 cases of biochemical tumor lysis. When we had venetoclax, as we can see by flow cytometry, there is a dramatic reduction of the amount of disease in the bone marrow. Venetoclax is quite active in reducing disease in the bone marrow. Those are the responses. Responses improve with time. Very high complete response, overall response rate, and very high complete response rate with high percentage of patients with MRD negativity by flow cytometry. Only 1 patient had progression with transformation to Richter, and again, we see flat lines that we are now used to. Toxicity was quite manageable, but venetoclax is myelosuppressive, so the use of growth factor for neutropenia is needed, and those adjustments are needed. Where are we taking this experience? We're taking to our future plans. In all our study, we now do next generation sequencing to the MRD6, again, because we are believers that the lower you take the disease, the longer the benefit the patients will receive. Our frontline study right now consists on a combination of venetoclax, obinutuzumab, and atezolizumab, that is a PD-L1 inhibitor. We have a study with acalabrutinib and venetoclax randomized to with and without obinutuzumab, and we have 2 studies of time-limited therapy with the 2 novel BTK inhibitor, acalabrutinib and zanubrutinib, combined with the CD20, where we are going to stop therapy regardless of response. This is the design for the frontline venetoclax obino atezo with a careful dose escalation, and venetoclax will start again on cycle 3. This is the design for the acalabrutinib plus venetoclax with the randomization plus minus obinutuzumab, because we all know that whereas venetoclax benefits from adding a monoclonal antibody, we are not sure that the BTK inhibitor will need a monoclonal antibody. This was a golden year for CLL. There were 4 publications of randomized study in the frontline therapy, all randomized toward the standard of care. All showed success for the new targeted therapy. 3 were published in the New England, 1 was published in Lancet Oncology. My AML colleagues are pretty jealous because we also publish in the New England the phase 2, so they are complaining that now CLL publishes in the New England anything. So just a quick impression of our current experience with CAR T-cell. We don't need to review this part. This was very elegantly reviewed before. We are participating in 2 CAR T-cell trials that are multi-center. This is the JCAR17 trial. The unique aspect of this is that those CAR T-cells are separately expanded with the CD4 and the CD8. So when they are reinfused at a 1-to-1 ratio. So it's clearly known what the mixture is. The data were presented at ASH last year. I know they will be re-updated, but I just wanted to show 2 of my patients. I've treated 4 patients so far. This is a 69-year-old male. He has mutated immunoglobulin heavy chain gene. He has TP53 mutation, POT1, SFB3. History started in 2001, goes through a series of regimen. In 2014 is treated on our clinical trial with ibrutinib plus rituximab, response, but then progressed. Treated with venetoclax, again a response, but at the time of initial progression we took him for JCAR17. Those were infused in May 2018. At that time, he had evidence of deletion 17p, and this was his disease. He had 80% bone marrow involvement, bulky lymphadenopathies, and a year later, in May of this year, when at one of the planned restaging, we can tell that he has no evidence of disease in the bone marrow and is in complete remission because there are no residual lymphadenopathies. Very similar on another patient, and the prior patient was 69 when entered the study. This patient is 72. Again, a TP53 mutated patient, went through a large number of treatment, was treated with venetoclax on the initial clinical trial, so received venetoclax before receiving ibrutinib, had a response, but then was stopped by her local oncologist because of cytopenia, was treated with ibrutinib, could not tolerate it because of severe rash, was treated with adelalisib, developed LFT elevation, was treated again with venetoclax and obinutuzumab since it was stopped for cytopenia, not for progression, had a response, but then was taken to the JCAR17 at time of initial progression. This patient was infused in October of 2018, and in July of this year, from 30% bone marrow involvement, there is no evidence of involvement in the bone marrow. She had bulky lymphadenopathies, and right now is a partial response because of a residual lymph node that is 1.7 by 1.3 centimeters. This is my little pet peeve. we are getting so much better with the treatment of CLL that now we are losing our patient to other cancers, we are losing our patient to infections, so we need to be really diligent in doing health maintenance, cancer screening, and preventive care. So at the conclusion, the timer was set at 10 minutes though. They are playing a trick on us. So I'm trying to put this 15 minutes talk in 10 minutes. In the conclusion, I think we have effective treatment. I think everyone will agree. Do we have time-limited treatment? This is questionable. I think we are getting there. Are the treatment oral? Yes. Are they chemo-free? Possibly. We really need to have a discussion with our mutated patient whether they want to do the short course of chemoimmunotherapy or they rather go the targeted therapy route. They are safe? I put a question mark, but last week we were at IWCLL in Edinburgh and they were presenting 7-year follow-up data on ibrutinib. So with all the toxicity that we know, I think these treatments are fairly safe. I kind of built my career by doing clinical trial on older patients, but I believe that this is something of the past. I think with the agent that we have now in CLL, we should stop talking about older, younger, everyone can tolerate this treatment. What we haven't made any stride is in this treatment being affordable because, I mean, CAR T-cell are extremely expensive, IFCG is expensive, combining venetoclax and ibrutinib, even if for a limited time, will break your bank account. So I don't think we are there. But thank you for your attention, and I would like to thank you, Dr. Martinelli and Dr. Scorzone, for the invitation. It's a great pleasure to be here.
Thank you. Thank you very much, Alessandro, for this nice view of what is the current research at MD Anderson and elsewhere. So, any questions for Dr. Ferraioli? Yes, Professor Cuneo?
Alessandro, you showed that those patients with IGHV mutated gene, if they achieve MRD negativity, the curves stand upright. What if the patient achieves MRD negativity and he or she is IGHV unmutated and they receive the FCR?
The curves continues to go down over time. So those have a 10 years progression-free survival that is in the order of 20 to 25% versus a 60%, and there is a drastic difference. The mutated, they truly plateau, starting after year 4 or 5. The unmutated is a gradual slope.
Could you just comment on the infectious toxicity of the IFCG protocol?
So the IFCG is myelosuppressive. So we use growth factor in all the patients. We didn't have any unexpected toxicity, probably because it's not a regimen that gives mucositis. It does not.
No.
Everyone in our institution is always on Valtrex prophylaxis. So I agree with some of the points that were made earlier on. With the targeted therapy, we should at least do the antiviral prophylaxis, and then if they are neutropenic, we need to intervene with growth factor and use prophylactic antibiotics. Okay. But we have not seen an excess of PCP or an excess of CMV or any of the other infections.
Good. Any other question? If not, thank you very much, Alessandra, and we move on to the next speaker. Antonio Cuneo from the University of Ferrara. Again, he doesn't need any introduction, very well-known CLL researcher, and he will discuss how I manage CLL in Italy.
Dear colleagues, Giovanni, you scheduled my presentation after Alessandra. What can I say? It's like watching a soccer game between Real Madrid and Liverpool and then Spal Bologna. So, how I manage CLL in Italy with many drugs and few doctors. Okay, this is the title, the correct title of the presentation. These are my disclosures. Predictive factor, do we use them? Of course we do. today we know that CLL develops through a few pathogenetic steps listed here: antigen stimulation of lymphocytes with specific BCR, cell activation, which depends on the IgG gene mutational status, interaction with the microenvironment, genetic features. Each of these pathogenetic steps are associated with prognostic or predictive markers, the most important being represented by TP53 disruption and the IgG mutational status. Alexandra showed us that the life expectancy of patients with favorable risk profile is similar to that of the general population, matched for sex and age. And here we see that in this Italian experience, which involved many Italian centers with patients treated with FCR, those patients with the TP53 disruption, the curve goes down. Those patients with immunoglobulin gene unmutated or 11q manus have an intermediate progression-free survival. Are there emerging prognostic or predictive factors? Maybe. I wish to draw your attention that on cytogenetic analysis, because we and others performed several observational studies. In this one, which we published a few years ago, over 300 patients seen at our unit between 2006 to 2016 were stratified by CLL International Prognostic Index and were also assessed for comorbidities and cytogenetic analysis. And to make a long story short, the International Prognostic Index stratified the probability of overall survival as expected, but having a complex karyotype had an independent unfavorable prognostic significance. And in this study, recently presented at EHA by the German group, comparing chlorambucil and obinutuzumab and venetoclax obinutuzumab in unfit patients, having a complex karyotype in those patients treated with chemoimmunotherapy was associated with an inferior progression-free survival, not so with venetoclax, suggesting that in those unfit patients treated with chlorambucil-based regimen, this marker may be predictive. Of course, it requires further validation. Data from trial. Okay, Alexandra already showed us the results of the last few years in CLL. And what we now have in our hands are a few relevant informations, starting from here. FCR improves survival and PFS over FC. PFS is better only in patients less than 65 years of age. This is a post-hoc analysis. Then we should consider that ibrutinib plus rituximab versus FCR improves survival, improves PFS only in immunoglobulin unmutated subset. And also we should consider that this is a comparison of PFS between continuous treatment and fixed duration treatment. We have information from CLL11 in unfit patients showing that we have an improvement by adding obinutuzumab over rituximab with a backbone consisting of chlorambucil in terms of PFS and perhaps overall survival. Yet the paper is not published yet. It was presented at EHA last year. We have information from the RESONATE-2, ibrutinib versus chlorambucil, improvement of overall survival despite crossover, even though the comparator arm is weak. And then the last three trials showing clearly that whatever you do with ibrutinib, with or without monoclonal antibodies, you have a better PFS in the mutated subset as compared with chemoimmunotherapy. You don't have, at the moment, a survival advantage. And these are the recently discussed, and soon they will be published, ESMO guidelines, suggesting that based on these data, we should offer as a preferred option new drugs to almost every patient. However, the European Medicine Agency recommended that in those trials comparing maintenance or continuous treatment with fixed duration treatment, additional endpoints are required to change clinical practice if there is no survival advantage. And this trial should also look for PFS2, so time to the second progression. It is intuitive. You compare continuous treatment versus fixed duration. It's an easy guess to anticipate that the continuous treatment will win in terms of PFS. And also, some well-reputed investigator published a few years ago in the National Cancer Institute journal the suggestion that the requirements for trials to change clinical practice if you compare maintenance treatment with fixed duration treatment should include overall survival, and they should show an overall survival advantage. And if this is not feasible because it would require a long-term observation, they should include endpoints such as quality of life or PFS2. If we move to the relapse refractory setting, I borrowed this slide from Gianluca, who is very generous with me, with many people, and I elected to choose the most challenging scenario because these are patients with relapse refractory CLL, TP53 disruption. And as you may see here, there is no room for chemoimmunotherapy, very low overall response rate, very short PFS at 1 year, compared to 80% of the patient free from progression in this unfavorable subset with ibrutinib, adenosine rituximab, or venetoclax. And these are the suggestions, again, of the ESMO, which will be soon published in Annals of Oncology by Barbara Akos and co-workers, suggesting that, again, if you have a short remission duration, you should go always with new drugs, no room for chemoimmunotherapy. However, these investigators suggest that if the response to the first line is quite long, more than 36 months, there is some room again for chemoimmunotherapy, even though new drugs are to be preferred. There are no trials comparing in the relapse refractory setting the efficacy of a second round of chemoimmunotherapy as against ibrutinib as first salvage treatment. So what we did within the GMEMA ERIC group and the UK program was to compare retrospectively the efficacy of bendamustine rituximab given in 237 patients in Italy and in Europe as first salvage treatment with ibrutinib in the UK and in Italy. The efficacy of BR second line here in Italy was a median follow-up 37 months, median PFS 25 months, median overall survival 74 months, and you see here the parameter predicting for a shorter PFS and multivariable analysis. Not unexpectedly, 17p minus and the immunoglobulin mutational status and stage were predictive for a shorter PFS. When comparing with a matched adjusted indirect comparison, selecting from the two series, including 137 patients treated with BR in second line after first line with chemoimmunotherapy. So we selected those patients treated in first line with chemoimmunotherapy, and we compared 137 patients receiving BR in second line with 71 patients receiving ibrutinib. We then adjusted for the imbalance in terms of time between first line and second line and P53 mutational status. In the end, we came up with 39 patients treated second line with ibrutinib and 92 patients treated second line BR, which were rather comparable in terms of characteristics. And you see here the survival curve, the black one is BR, the red one is ibrutinib, so that no difference in survival was noticed in this retrospective analysis. So, treatment algorithms. We should consider what we have in Italy. We have some restriction, maybe the people from the US are not aware that we are allowed to use ibrutinib if in first line, if there is TP53 disruption, in second line without TP53 disruption, only in patient 7 years old or older or 65 to 69 with at least one comorbidity. Why this? This is a restriction put by Italian Agency for Drug based on the inclusion criteria of the Resonate 2 trial. Then we can use idelalisib and rituximab in 17p disrupted in patients not eligible to other therapies, venetoclax in patients unsuited who have failed the BCR inhibitor. We can't use in first line idelalisib and rituximab if there is no P50 disruption, venetoclax the same. And concerning venetoclax and rituximab, we are not allowed to use it in first line, and it will be hopefully soon available in the relapse refractory setting. So based on this restriction, which is my suggestion, my personal view as of today, if you have a first-line treatment, fit patient, no TP50 disruption, IgG mutated, FCR or BR if the patient is 65 or older. If the patient has a TP53 disruption, no question, the new drugs. If there is IgG unmutated, hopefully ibrutinib, but we have a restriction. If the patient is unfit and there is no P53 disruption and the immunoglobulin gene is mutated, I would offer colambricib plus an anti-CD20 antibody. Suppose the patient has the unmutated configuration of the immunoglobulin gene, I would hopefully offer ibrutinib, and I would consider complex karyotype as a suggestion towards new drugs. Of course, allogeneic bone marrow transplantation has a limited role in highly selected cases in first line. Concerning second line, this is my viewpoint. If the progression-free survival is very long and there is no unfavorable genetic marker, I would offer new drugs or chemoimmunotherapy. If the patient has unfavorable characteristic, genetically based or due to stage or unfit for chemo, I would go with the new drugs, reserving allogeneic transplantation for highly selected cases. How do we choose between the different new drugs in the clinical practice? Again, this is a viewpoint. I would consider the length of follow-up of clinical trials with the different drugs. I would consider comorbidities and the characteristics of the patient population enrolled in trial. So here, ibrutinib has the longest follow-up today and has offered us reproducible data in all trials. Idelalisib was tested in elderly patients with cytopenia and a number of comorbidities, and also with ECOG performance status 2, which were not included in other trials. Venetoclax, with or without rituximab, has the clear advantage of being fixed duration, MRD negative, few drug-related adverse events, and it represents the ideal bridge to transplant because it reduces the size of disease. Ibrutinib, you should be careful when there is cardiac comorbidity or the need of anticoagulant treatment. Idelalisib have a very cumbersome safety profile, and venetoclax has a relatively shorter follow-up than ibrutinib. It's now 36 months, and the tumor lysis syndrome, which should be prevented. And what in the clinical practice if we fail with one new drug? Well, we have the solid line indicates data in prospective trial. We know that after ibrutinib or idelalisib, venetoclax works. Retrospective analysis show that after venetoclax or idelalisib, ibrutinib may work. And the last slide, I would like to comment that with you, dear colleagues, that I was impressed as a young student when I read for the first time in my life this beautiful sentence in the first edition of the Harrison textbook of medicine, saying there is no greater opportunity, responsibility, or obligation for a doctor, for a human being, than becoming a doctor. And today I think that responsibility, obligation is to consider sustainability in the clinical practice. Thank you so much.
Thank you very much, Antonio. Nice talk, really, with many insights. Questions? You mentioned, you want, no.
Go ahead. I just have a quick question. I noticed that you had venetoclax with and without rituximab on your schema, and you had idelalisib as the frontline treatment. So what is your impression? I mean, you have them there, or are you truly using them?
No, idelalisib in first line is the last resource only when any other drug is not indicated, and we are referring to the p53 disrupted patients.
That is because the safety in the front line is worse than the safety in the relapse because of more likely autoimmune mediated in the frontline patient that are more immunocompetent.
There is a very high dropout due to toxicity.
You mentioned the relevance of overall survival based on the EMA and the editorial in the JNCI, but perhaps I might be wrong. I don't really remember recent trials with overall survival as a primary endpoint.
Okay, it cannot be a
So it might be a bit of a schizophrenic scenario in which
if you use
they...
I perfectly agree, yeah. I mean, if you use overall survival as a primary endpoint, you need 10 years of observation, you deny good drugs to bring into the market. However, if you at least include, if overall survival, what EMA says is that if overall survival cannot be measured in a short time, you should use PFS2 when you compare fixed duration versus maintenance or continuous treatment. This is the suggestion.
What about measurable residual disease as a surrogate for response?
Yeah, it's becoming increasingly credible. So maybe instead of PFS2, they will accept to use the MRD. Of course, there is a problem of feasibility because you need certified laboratories.
Because the FDA recently agreed to use MRD as an endpoint.
I would feel more confident, even though you told us that if you are IgG unmutated, you achieve MRD negativity, then the curve continues to go down.
Just a quick thing, you mentioned sustainability in your last slide, but do we have any solid pharmacoeconomic studies comparing fixed duration treatment first line versus continuous treatment with the BCR inhibitors? So venetoclax-based fixed duration versus continuous treatment with BCR inhibitors, either first line or second line. Do we have any pharmacoeconomic studies?
Yeah. There are a number of pharmacoeconomic studies which are company-sponsored. So I think we would need independent studies.
Thank you. So we will now continue this very interesting session with our friend and colleague, Professor Massimo Massaia, will be discussing the role of measurable residual disease in chronic lymphocytic leukemia.
Thank you very much. I also would like to thank the organizers for the invitation and also the previous speakers, because you have already touched a little bit what I'm going to say. And so these are my disclosures. So these are the tools we have right now based on the international working group on CLL to define a response in CLL patients receiving treatments. And my talk will be about the assessment of minimal residual disease. As you can see, something that is not generally indicated in general practice, but is suggested, is desirable in clinical trials. And these are the reasons that makes desirable to do MRD assessment. When you are interrogating the efficacy of a treatment which was given to achieve disease eradication. So you want to see if you have really gone deeper into inducing the disease eradication. Of course, it's not useful if you are giving a treatment which is just trying to achieve disease control. And what was recommended actually was that in these studies should report the sensitivity of the method and also if this was tested in blood or marrow, and also to express this as a value to refer to the total number of patients treated. Not, of course, if you treat 10 patients, 10 of them go into CR and 9 of them are MRD negative, you can't say that you have 90% of MRD negativity in your study. You have 9% of negative MRD. So is MRD achievement something we should invest, we spend time and money on, or is a meaningful goal? And this is a slide by Andy Rostron saying yes, because if just making very general analysis coming from more than 20 trials, you can see that you have about 2 years, from 1 to 2 years differences in PFS between patients who are in complete remission but still with detectable minimal residual disease compared to those who do not have minimal residual disease detectable. This is another study coming from the German group and showing that this is a very long follow-up, 18 years follow-up, several chemoimmunotherapy studies put together. These are all patients who are in CR or PR after chemoimmunotherapy. You can see that if at the end of the treatment patients had less than 1/10 to the 4 residual CLL cells, it's much better than being in between or having more than, and this is both for PFS and for survival. So I would say that yes, the answer is a meaningful goal, and it's interesting that the discussion you just had about the surrogate endpoints, can MRD become a surrogate endpoint for PFS? And of course we need something that can be predicted that MRD is somehow measuring PFS, is very strongly correlated to PFS, and this is a model showing that this is the case. And based on this, as I said before, the minimal residual disease and endpoint in chronic lymphocytic leukemia studies has been approved by EMA, and as Dr. Ferraioli just said, also been approved by FDA. So it makes very sense because, as you said, Antonio, we need to make available new drugs, and we cannot wait. Also, PFS1 could be very long. So, and so the other question is, but to use this as we need to have assays which are standardized to use MRD as a surrogate for PFS, and to include this primary endpoint in clinical studies. And the answer is yes. This is a very, very complicated table. It's a recent paper making nice comparison between different assays. But the point I would like to make is this one. Basically, flow cytometry has been harmonized by Eric, and also PCR has been harmonized, and NGS is ongoing. So so we have in our hands tools, and as also was said before, we need to have laboratories that the answer they give are, of course, are reliable. So the next point is, are all MRD created equal? And I think this is probably, I think when I was preparing the talk, what I find most interesting. I think no, they are not all equal. And if you take this, the definition according to international workshop on CLL, this is the minus the 10 to the 4, and this is FCR, MRD negative FCR. This is MRD negative BR. You can see these are different months, and you see this is chlorambucil and obinutuzumab, and this is chlorambucil and rituximab. They're not the same. So MRD negativity is better to be MRD negativity after FCR, then BR, then chlorambucil. So meaning that probably we're not detecting, we are probably below the threshold to see the residual disease. And so we are basically, these are the clinical definition of response in CLL. And we are somehow here in this gray zone, I would say. So MRD negativity because are below this threshold. But as Dr. Ferraioli said, so if we use this assay, of course, sorry, I would say that, okay, so I would like to come back, but I don't know if I will be able. So, but, well, was negative. But if I use another assay, 10 to the minus 5, this will be positive, but those who are negative before have become positive, this will be negative. But if I go even deeper using what Dr. Ferraioli said, like the NGS, even this could become positive. So in this interval. And this will be negative, will be positive, we don't know. So, and I think that this is the reason why we are beginning to call not minimal residual disease, but measurable residual disease or undetectable minimal residual disease. Probably is more appropriate. And indeed, as anticipated by Alessandra, when they did this work to look at the minimal residual disease by NGS, they could see that most patients with MRD4 by flow, they were MRD positive by NGS because they went deeper into the detection of residual CLL cells. And this has already been shown. As you can see that there is a clear-cut correlation between the number of residual CLL cells in the bone marrow and the duration of progression-free, something that was already anticipated by Rostron, showing again the same thing in the bone marrow. It's interesting to see that almost 1 log decrease of residual CLL cell means almost 10, 12 months duration of progression-free survival. So the other question is MRD achievable with the small molecules? And the answer is using single-agent ibrutinib, probably not, because we know the way it works, so it takes time, even if, amazingly, so far probably it's the best, it's a front line, is giving the best PFS, but it's a work in a different way. Probably single-agent venetoclax, yes, because it's able to induce CR with MRD negativity even in the relapse or refractory setting. So of course it makes sense to combine. So MRD is often, nowadays is often achievable easily, probably more easy than before to be achieved by appropriate combination. And what we can do, we heard the combination of FCR with chemoimmunotherapy plus the new drugs, or the combination of the new molecules plus the antibodies, etc. So we have different tools. And indeed, as you can see, by using this combination, this is the study that Alessandra you just showed us. This is in the bone marrow. So FC plus GR101 and ibrutinib. So you can see that it's very easy. It's very easy. I mean, not easy, but it's possible to get very high percentage of MRD, of complete remission and MRD negativity. So, and the last point has already been touched upon by Dr. Ferraioli. So it's time to move to MRD-driven treatments. And not yet, of course, we are waiting the results of clinical studies that are working to harmonize, as I said before, the different assays, because we can look at the minimal residual disease by flow, next generation flow, by digital droplet PCR, by NGS. The issue is where we should look for minimal residual disease. So we know that CLL is a disease, is a multi-compartment disease. So it's not only in the blood, it's not only in the bone marrow, it's also in the spleen, the lymph node. And I'm pleased that Dr. Zamani before presented us data about the combination of MRD plus, let's say, PET, we do not have something similar in CLL to look at the residual, to functionally look at the minimal residual disease. We have, of course, CT, but nothing like PET in myeloma, or I would say something like in follicular lymphoma, where it has been shown that the metabolic tumor volume by PET and circulating tumor DNA was able to, by combining together the two assays, was given very informative information about the duration of PFS. And the paper by Alessandra and co-workers from the MD Anderson, the same paper we mentioned before, tells us that actually looking at circulating tumor DNA in plasma by NGS is not reliable in CLL at this point. So in CLL, so far, the best compartment to look at is the bone marrow. We want to have really the strongest indication, we have to go with the bone marrow. And when we will have this information, so bone marrow or whatever, then we can move to real-life data. I think it's the suggestion now is, when possible, to look at MRD also in the future, and based on this, we can start to use clinically. And as said very nicely by the data that the clinical trials presented by Alessandra, we have two possibilities, somehow something similar to PET in Hodgkin disease. So we can imagine to discontinuate the treatment. Probably in this case, this MRD6 will be a safe threshold, because we know that the disease, the residual disease is very low. Probably it's better, it's safer than using MRD4 to downgrade the treatment. Worse, it could be, sorry, I'm not, okay. Well, it could be probably the opposite. If we want to intensify the treatment because we are not happy about the treatment, probably we have to use this threshold. And this is just an example, and in maintenance, and this is just an example, so just very quickly, as you can see, this is just a hypothesis to stop before. So the final thoughts are that MRD evaluation is clinically meaningful, and so far is more meaningful on PFS than overall survival, and especially after chemoimmunotherapy. We are in the middle of getting data with the new drugs. The second point is that is achievable with the new agents in combination with chemoimmunotherapy or antibodies. No evidence so far to use it in clinically in the clinical practice, but probably very soon or later will be useful for that. And something that I think is interesting, that if we can shorten the time of treatment, it's important, because for chemoimmunotherapy it's very important, because besides second myelodysplasia, acute leukemias, but also mutations, because we know that when we give FCR, we can induce P53 subclones, we could expand. But the same is also true with other new drugs. We know that ibrutinib is inducing, after maybe years of treatment, could induce some mutation. So probably to have something that is, we can shorten the duration of treatment, could be useful to prevent the occurrence of mutation. And of course, as said before, saving resources and improving patient comfort is another important issue. And I finish here, and I take the liberty, can I present, if you have time next year, you want to come to Cuneo City, which is New York City, Cuneo City, so it's almost the same place. There is a meeting on immunotherapy and hematological malignancies. Many of you have already been involved, so, and thank you for your attention.
Thank you, Professor Massaia. Any questions? Professor Martinelli?
I come from chronic myeloid leukemia, so it's easier for me to try to understand if a short treatment with the best in town possibility in combination will provide a complete molecular response, and even if deep or not deep can be discussed, but in chronic myeloid leukemia, we were able to reduce, to stop the treatment of 25% of the entire population, even they are younger. And we can probably be able to rescue the people that are not able to they stop it and they come back to MRD positivity. So what do you think about the opportunity to use strongly in a short time what's the best in town, and then to stop the treatment, because the sustainability of the process will be related to the cost, just to the cost to the drug, not to the entire treatment, which could be hospitalization, infusion of the drugs, day hospital, and so on. So personally, I'm quite in favor. I'm not an expert in CLL, but I'm quite in favor to use a short time exposure, one drugs for 1 year, and then eventually try to suspend as much as possible, and waiting for recovery of a chronic leukemia, which is sometimes an accumulation of not apoptotic cells that accumulate in the bone marrow. I don't know if it is a sort of a simplified way to...
No, I think it makes sense. You are lucky because you have CML is a little bit different, less driving mutation. So, but probably the only drug that so far we can think about giving a single drug and to stop is venetoclax. There are no other evidence. We don't know if patients receiving ibrutinib is 5, 7 years people, and we don't know if we stop them, they will relapse or not. We don't know. So far, nobody has tried to. You're right, but it took to CML people how many years to decide it was time to to stop treatment after giving TK inhibitor? So several years. So, and probably if we have MRD assays like MRD6, and you have twice every the demonstration you are very low, probably that could be a possibility. But generally speaking, I would like to use a combination. This is, of course, I would like to treat the patient for 1 year with the 2 best drugs I have for the first line, and then because the best results are in first line for any disease. So
it looks like they use sequentially in the algorithm that Antonio has presented, a sort of takes the drugs for the future. I'm now in a solid tumor institution, and they do the same with breast cancer or for other cancer, to take the drugs for the next relapse situation. So it's a sort of agony.
Yes, but the same in myeloma. In myeloma, we did the same reasoning to keep the best drug for later on, because you may never know. I think that is not the right, to me, it's not the best strategy. The best strategy is to use the best drug from the very beginning, and you have 2 drugs that can be combined together and are synergistic. Probably will use both. I will not keep, just say for the future. The first remission is always the longest you can get. So,
I think we need to take the discussion at the coffee, at the next coffee or dinner break. Excellent presentation. Thank you. And it's now my pleasure to introduce the co-chair, Dr. Gianluca Gaetano. Truly doesn't need introduction, and he will be discussing biology and treatment of Richter syndrome. Professor Gaetano.
Thanks a lot, Alessandra. Thanks a lot, Giovanni, for this invitation here today. It's a great pleasure. I will talk about a bit of a neglected disease, Richter transformation. These are my disclosures. So, as you know, the vast majority of Richter syndrome is represented by diffuse large B-cell lymphoma, even though a small proportion of cases are, in fact, with a Hodgkin lymphoma histology, and we'll see a bit more about this. Now, when should we suspect Richter transformation? It's obviously a clinical suspicion in the presence of bulky disease, extranodal involvement, B symptoms, very high LDH, but none of these would be obviously diagnostic of Richter. So to reach a diagnosis of Richter, you need a biopsy, with a histological diagnosis. And the biopsy should be ideally PET guided in order to pick up the lymph node or the site, because it might also be an extracellular site with the highest SUV. Now, importantly, and this again is something that is not usually assessed, it's important to define the clonal relationship of Richter, especially in young patients who may be candidates for transplant. The vast majority of cases, more or less 80%, are clonally related, so it's a true transformation from CLL to Richter, and that you can easily assess by testing immunoglobulin gene status. But there is a fraction of cases that actually are type of de novo diffuse large B-cell lymphoma. They are not related to the CLL clone, and this is now recognized by different institutions as two separate entities, even though this is not, as I said, usually assessed. It may not be needed for the elderly patients, but might be useful for the young ones. The outcome of these two entities is different, as you can see here from the curve. The red curve is the clonally related, the blue curve is the clonally unrelated, and these were relatively old data we generated with Davide Rossi some time ago. And we also know that the genotype is different. The disruption of p53 reaches 60% in the clonally related cases. Now, as I said, we have these two variants recognized by the WHO, diffuse large B-cell lymphoma and Hodgkin lymphoma variants, as you see for the DLBCL variant, and mainly for the clonally related cases, which are the majority. The median overall survival is really very unfavorable, less than 1 year, and there's not much of a progress. Most cases are EBV negative, while instead for the Hodgkin lymphoma variant, as you see in the bottom panel, the median overall survival is certainly more favorable. Many of these cases are in fact EBV positive. The 2016 classification of Richter syndrome recognizes these entities, as we said, and I think it's really important, the histologic diagnosis, to make a distinction between true Richter versus prolymphocyted progression versus a second cancer that may be PET positive. So you really need diagnosis, and you do see that compared to progressive CLL, Richter syndrome really has a very poor survival. PET has a negative predictive value of 97%, so that is obviously, and the MD Anderson data were very important to reach these conclusions, and other studies corroborated. The cumulative incidence of Richter in the past, so in the chemoimmunotherapy or chemotherapy era, is represented here in this graph, as you see, more or less 0.5% per year of observation. But even now, with the new agents, Richter syndrome is still there. If you look at the last column, you do see, in fact, here, you do see the prevalence in many of these trials with the new agents. You have to consider that many of these patients actually had been exposed to chemotherapy before, and that might have selected chemo-refractory subclone. Even with the new agents, as we knew in the past, Richter syndromes tend to be an early event, so usually within the first 2 years, and this is something that leads us to conclude that it's the CLL clone that is really predisposed to genetic transformation. And in fact, we know that characteristics, genetic characteristics of the CLL clone have an effect, influence the risk of progression. We showed several years ago that this specific immunoglobulin gene, IGHV439, that carries a stereotype B-cell receptor called subset 8, has a very high risk of Richter syndrome transformation, especially if coupled with mutations of Notch1. Now, Kostas Stamatopoulos later on clarified why subset 8 is so important for Richter. The cells carrying subset 8 B-cell receptor respond avidly through the B-cell receptor to many different antigens. They proliferate, and they have an aggressive metabolic profile. We also know that Richter once it's transformed, it really carries very aggressive genetic alterations that are represented in this slide. 40% of the cases have alterations of MYC, amplification or translocations like Burkitt. 67% of the cases have p53 abnormalities, which obviously render the clone chemorefractory. CDKN2A deletion occur in 30% of the cases. Subset 8 we already said before, and the notch signaling mutations are present in 30% of the cases. So really a genotype that associates with a rapidly progressive kinetics and with chemorefractoriness. In the era of the new drug, we also know that Richter syndrome may associate with mutations of BTK, and it is listed here, or PLC gamma 2, in patients who developed Richter while on ibrutinib, even though many of the patients actually carry other genetic mechanisms. So ibrutinib resistance and Richter transformation are, in a way, two independent biological phenomena. Now, treatment failure is one of the major aspects of Richter syndrome, and there are many reasons for that. The lack of dedicated treatments is still today, the frailty of patients, the late recognition of the disease, because, as I said, people just don't think about that. Now, overall, although many attempts have been made, and these are the list of these many attempts, R-CHOP and OFER was developed by MD Anderson, are the best available induction treatments in order to obtain some type of response, and this is the overall response rate that you see here with the different schemes. R-CHOP is probably most widely used in Europe. The UK group tried O-CHOP with ofatumumab, but there was no real advantage in this regimen, so R-CHOP is the one that we tend to use in Europe. OFER might be used in, I don't know whether MD Anderson still uses OFER, but I think there's never been a comparison of the two, so there's a certain toxicity associated with OFER. Post-remission stem cell transplant is a potentially curative approach for Richter syndrome, and I think for the clonally related patients, it is really the only option that we have in order to offer a potential cure with the patients. These are the ABMT data, and you see with allogeneic stem cell transplant. But obviously, it's a very small fraction of patients who can be candidates to allogeneic stem cell transplant because of donors and especially because of age. We don't really have strong evidence with the new drugs, or at least we are not there yet. There are several trials going on, and also an Italian study coordinated by Marco Montillo will start soon with novel agents, but still it's a long way to go. I think these are the results with some of the new drugs, but again, none of them, as per itself, proved to be really the way to go for Richter syndrome. How should we address Richter in our clinical practice? This is what we usually do at our site, but also, and this we shared with Davide Rossi, but also with several other investigators. So once we have a clinical suspicion of Richter, we feel that PET is important for several reasons. First, to do a PET-tailored biopsy. If the PET-tailored biopsy documents a diffuse large B-cell lymphoma, then assessing the clonal relationship, at least in patients who might be candidate to transplant, might be relevant. For clonally related Richter, then R-CHOP or another regimen, as we said, followed, if possible, by transplant, ideally allogeneic. For the clonally unrelated Richter, then we manage them as de novo, diffuse large B-cell lymphoma. We understand that this algorithm may not always be put in place in the clinical practice because sometimes the patients are too frail. The lymph node with the highest SUV might be an abdominal deep lymph node, difficult to biopsy. So we understand of the many pitfalls in this context. So just to sum up, The genotype of Richter sustains the clinical aggressiveness and chemorefractoriness of the disease. A molecular workup to distinguish clonally related versus clonally unrelated might be useful. In relapsed refractory CLL treated with BCR inhibitors and BCL2 inhibitors, development of Richter occurs early and may reflect an aggressive clone potentially selected by previous chemo. The outcome of Richter is still poor today and mandates the investigation of new treatment modalities. I think these should be really vast trials because the disease is rare, so we really have to join forces together. And the incidence, biology, and clinical behavior of Richter syndrome in patients receiving only chemo-free regimens still need to be defined on the long run. These are the many people we've been collaborating with on this topic. Thank you very much.
Any questions for Professor Gaetano? Professor Martinelli?
The involvement of MYC rearrangement, MYC mutation, MYC disruption, and whatever, mostly of the case, MYC overexpression or deregulation, is constantly in any types of progression and transformation of cancer. We are not searching too much this MYC overexpression. We don't have the possibility to, in the panel or in analysis to analyze the MYC overexpression. How did you suggest to extensively use, because there was a presentation 5 days ago in Cesena, Bolli was present, and he was also suggesting that MGAS with MYC alteration progressed very quickly to myeloma. So MYC became a sort of candidate for transformation. Any comment how we can study better MYC?
So, well, first of all, I think we should, keep distinct overexpression on one side by immunohistochemistry versus genetic alterations that not necessarily will lead to overexpression. They may lead to deregulated expression, but that doesn't really mean overexpression. So what we know in Richter is in fact the genetic alterations, but the picture is similar in diffuse large B-cell lymphoma. How to apply that in the clinical practice and why should we apply that? I think we should search for these markers if then that will, in the clinical practice, if that will help us to choose a specific treatment. This is not the case today. So the diagnosis of Richter is not based on the fact that you have a genetic alteration of MYC. It is based on histology. And having or not having MYC translocation or amplification today will not make a difference in the treatment choice. So I'm not really sure we have to do this test necessarily. We can do it for research purposes, but as of today, it is not a predictor of treatment. So, and it is not also a diagnostic marker. It allows us to understand why these tumors are so aggressive. But we don't have MYC inhibitors, even though they've been searched for. You probably, in the future, but not as of today.
Yeah, you're right. We don't have any MYC director modulator. But if we are using, for instance, we are currently using idazanutlin, the MDM2 inhibitors. And when you shut off the MDM2, you upregulate P53. When you upregulate P53, MYC come down. So there is a sort of a balance between MYC and P53, even if not.
Does that happen also in the context of a translocation of MYC, or only in overexpressing cases? Because this is
in the phase 1, even if large phase 1, we get 120 patients with an acute myeloid leukemia, we don't get this data. Okay. But probably in the randomized study, which is now completed, we get 340 patients. Probably we get more information. But however, it looks like from preclinical study that the modulation of MDM2 can be able to restore P53 functionally inactivated and then shut off the MYC. Is that something that, of course, is simple and sufficiently simple, and the drugs will be probably available in a short time, starting from acute myeloid leukemia and moving to the lymphoproliferative disease. So,
now that would certainly be an interesting option to explore. And the genomics and the genetics and genomics of Richter is very similar to transformed follicular lymphoma, for example, or at least they share many aspects. And also, for example, transformed marginal zone lymphoma. So they share many different aspects. So once you find the right way, it will be helpful for several disorders, transformed from indolent B cell to aggressive B cell.
Thank you.
thanks.
So this will conclude the CLR session. Thank you.
So we are moving to the conclusion of the meeting, and just to say thanks, I don't believe we have time and energy for the few people that are still remaining to say what's the future of MD Anderson Cancer Center. We see the future of the MD Anderson Cancer Center. I would like just to say thanks for all the participants, particularly the faculty of MD Anderson Cancer Center and all the speakers for their very exciting presentation. We get a lot of opportunity to collaborate in the future to go together, and so I would like to thank all the participants of this opportunity. This is the first SOHO Italy, which is now probably became a society. We are closing to get the issue of Italian Society of Oncology, Hematology and Oncology, which could be probably a better instrument for getting opportunity for young people to come next year. We get now the next year date of the next meeting. It could be a great opportunity for the young people to get access to the new therapy and the new ideas coming from the hematological and oncology community, particularly inspired by MD Anderson Cancer Center team, leukemia team. So thanks for coming. It is a great pleasure for me, and I would like to share the congratulations with Abu Kantar.
See you next year, I hope.
Okay.
So second annual conference will be in September 2020, 23, 24 and 25. And now we are proud and honored to announce the creation of SOHO Italy, which will be co-chaired by me and Giovanni Martinelli, and Professor Cantarger will be the honorary president of this society. Scientific board will be composed by Marina Konopleva, Naval Daver, Eli Jabur, and all the other colleagues who were part of the scientific board of this first Italian conference. And we hope that during the year we will be able to give scientific contents, formation, everything in soul spirit together with the American colleagues. Thank you for coming, and thank you for all for your presence here.
Have a nice trip back.
Have a nice travel back, yeah.